Team, happy Friday. Welcome to yet another version of RLR, though the presence of the more esteemed, smarter, kinder, more charismatic R is uncertain. We'll see if he's able to make it or not. I'm very, very excited to share the stage with other incredible Academy members. Today is a very familiar feeling for me. It's a feeling of like excitement, but also like what is it? Gosh, I don't know. I don't know if there's a word. I feel like I'm going to have to intensely scrutinize everything. That's because Anmol is presenting a case. And if you've ever been part of an Anmol case, you know that you think you have to go right, but then you have to go left, and then you have to look up, then down, then like turn around, and you end up dancing very, very awkwardly. So I'm very, very excited for the intellectual challenge. She says it's short and sweet, but I will mark my words. I don't trust anything about that. I believe everything else she says, except her description of her cases. So Anmol, let me hand the mic to you to say hello, and then we can introduce everybody else who's part of this session.
Hello, everyone. Thank you so much for coming today. My name is Anmol Preet Kaur, and I am an international medical graduate from Punjab, India. I've been a member at Clinical Problem Solver since 2023, and my passion for clinical reasoning has increased many folds. And I love being here. I love being here. And my case is indeed short and sweet, but it was an eye opener for me. But I hope that we all can learn something new today.
Incredible. Thank you so much, Anmol. Today on scribing, we have Zachariah, who is across oceans from you, Anmol, and me in South Africa. Zachariah, I'll hand the mic to you to introduce yourself to folks and maybe give those who know you a little bit of an update on your life.
Hi everyone, I'm Zakaria, international medical graduate from South Africa. Cape Town has just been so cold, and the winter, we're heading towards winter. It's just cold and rainy. You just feel like staying indoors most of
How old does it get?
Not that cold, but I think because of the wind,
I see.
Cape Town is a very windy and rainy winters.
I see. Yeah, the wind makes a huge difference. My wife and I were on a run today, and when we were running into the wind, it felt perfect. And then all of a sudden, when we were running with the wind to our back, it was so hot. It's unreal how much of a difference it makes. I see Saket, who is here very, very close, is doing teaching points, is very well prepared for the California wind. I saw this morning on a rapid fire, Saket, you were cloaked and very well shielded from the weather. I'll hand the mic to you to say hi and maybe tell folks a little bit about yourself.
Hello everyone. Right now, and I'm still getting used to the time difference since I just got back from India. I'm really excited for the case today. I'm an IMG from Hyderabad, India.
Incredible. Very, very nice to have you. Saket is one of our newest members of the Academy. We're thrilled to have him, and I'm excited to hopefully see him soon since we're in a very close geographical proximity. If Prof. Rez doesn't show up, what we'll try to do is a little bit more breakout rooms and a little bit more of a dialogue with everybody here. And so without further delay, Anmol, maybe when Zachariah can share his screen, we can jump right into your first aliquot.
Okay, so I have divided this case into around 5 aliquots, and the chief complaint is basically vomiting and loose stools for one day. A little bit about it. The history of present illness is that it is a case of a 78 years old female who came to the emergency department with a complaint of multiple episodes of vomiting and loose stools since the day before. The stools were reportedly watery, without any blood or mucus. There was no history of any recent fever. The symptoms were associated with diffuse abdominal pain, and there was no chest pain, cough, or shortness of breath. She went to an outside hospital, found to be hemodynamically unstable there. So they did some initial stabilization and referred the patient to our center for further management. So the key points are basically multiple episodes of vomiting and loose stools for a day associated with diffuse abdominal pain.
Fascinating, Anmol. I think This is a very, very familiar place for many people. And I think that even though vomiting and diarrhea are closely proximal symptoms in terms of their associations in our cognitive spheres, they're actually very distant symptoms. Diarrhea or loose stools requires dysfunction of the small or large bowel, and vomiting requires a problem in the stomach or above. And so even though they're linked together, in our minds, they're actually very discrete processes. They're linked together because essentially they emphasize the very real possibility of an acute pan-gastrointestinal disorder. And so what that means is when somebody has a simultaneous onset of nausea, vomiting, and diarrhea, their entire GI tract is likely affected. And so that's the term gastrostomach nausea, enteritis, diarrhea. And so acute gastroenteritis is the clinical syndrome here. And the question is, are there any things that are incompatible with that? And the answer is maybe. Hypotension, especially hypovolemic hypotension, certainly isn't incompatible with that. In fact, it's a very anticipated consequence of that. Though I would say that the degree of nausea and vomiting and diarrhea required to get hypovolemic shock is very, very marked. And so if the patient has only had 2 or 3 episodes of the same, you'd have to be careful. But here it seems like the amount that she's having both from above and below is certainly in proportion to that, what would be expected with hypotension. What may possibly be rather uncharacteristic is her pain. And so to understand that, let me explain what the gastrointestinal innervation is. And on the inside of the GI tract within the lumen, there is basically no innervation, which is why most gastrointestinal bleeds are painless, and which is why an EGD and colonoscopy does not require aggressive anesthesia for it to be performed. And so when somebody is having abdominal pain alongside what was initially felt to be a enterocolitis of the internal lining of the GI tract, you have to step back and say, well, hey, if that inside of the GI tract is what's causing the nausea, vomiting, and diarrhea, the patient should have minimal to no pain. And so what we are going to do on exam is to study how much discomfort does the patient appear to be in versus how much diarrhea, nausea, and vomiting does she have. And if the ratio is very luminal predominant with much more nausea, vomiting, diarrhea, and just a little bit of pain, I think that's not incompatible with the working hypothesis of gastroenteritis. If, however, we realize that her pain is more and more prominent, we either have to reassess the hypothesis that the disease is actually on the inside of the GI tract and wonder whether we have misrepresented the problem, or whether she has had what was initially a disease limited to her lumen, but now has invaded beyond it. So a classic example would be an invasive gastroenteritis, one which is expected to just affect the internal wall in most people, but can internal lumen, but can cross into the wall. And these are what essentially are conditions that are often heralded by the change in the color of the vomitus or the stool from clear to bloody. And so you'll start to see people having bloody diarrhea and bloody emesis. The alternative hypothesis is that the patient doesn't have a disease in the lumen that invades into the wall, but rather that the disease is of the wall itself. And a classic example is inflammatory bowel disease or Crohn's. So I think here, this is a classic case of gastroenteritis, unless the patient has prominent pain on exam or prominent pain with palpation, in which case the lumen is no longer a sufficient explanation for the location of the disease, which was either a disease of the abdominal wall from the very get-go, like IBD, or an invasive enterocolitis. So I'm really, really eager to see what this patient's exam looks like, and that's probably what would happen next in real life. But I will tell you, in terms of the typical order of presentation, the things to pay attention to now are the immune status of the patient. And if this patient has any underlying immunocompromising condition, that will certainly increase the risk of an invasive infection. I would also be paying attention to any hypotensive or nephrotoxic medications the patient's on, because those can either contribute to hypotension or contribute to the most common complication of diarrhea, nausea, and vomiting, which is acute kidney injury. So if she's on an ACE or an ARB or something like that, I'd be really, really attentive to that. All right, Mike, to you, Anmol.
Wonderful discussion. And for the next aliquot, we talk about the past medical history. So she has a past medical history of hypertension and coronary artery disease, which was diagnosed 3 months back, and it is being managed medically. She's basically having mild left ventricular dysfunction with an ejection fraction of 40 to 42% in her last echocardiographic assessment. In her last admission 3 months back, she had sudden onset dyspnea, was intubated outside and referred to our center. And that's when ECG changes were seen and she was diagnosed as coronary artery disease. The patient is basically on multiple medications. One is she's taking dual antiplatelet, aspirin, clopidogrel 75 once daily, atorvastatin 40 once daily, an anti-anginal trimetazidine MR twice daily, beta blocker metoprolol 50 mg once a day, ramipril 2.5 mg once a day, and a combination of spironolactone plus furosemide 50 by 20 once daily, a proton pump inhibitor, and an anxiolytic. So these are the medicines she's taking. The family history is non-significant, and there are no known allergies. She has no history of any recent travel, does not drink alcohol, and does not smoke, and there is no known animal exposure. I would briefly stop here.
Yeah, I think this is a very, very interesting setup, Anmol, because I think whenever somebody has any abdominal concerns, especially with nausea, you have to worry about coronary disease in somebody over the age of 50. And I think when somebody has that, you have to worry even more. A big counter argument to this being the presentation of acute coronary syndrome is the presence of diarrhea. And so you would want to verify the severity and significance of the diarrhea. And the more and more prominent it is, the less and less likely somebody has acute myocardial infarction causing this constellation of symptoms, but none of these things are strong enough to prevent you from getting an EKG, and depending on the EKG, a troponin. So an EKG is always necessary in this patient. I think what you have shown us here is the vulnerability of the patient to a hemodynamic insult. And I think you can see that these medications, while excellent for coronary health and heart disease, put the patient at significant risk when they develop an independent hemodynamic insult. So this patient's ability to tolerate hypotension and volume loss is much less because of the presence of afterload reduction in the form of spironolactone and an ACE inhibitor in the form of induced chronotropic incompetence from the metoprolol, and of course, not to mention the diuretic that she's on. So the real question is, how much of her current clinical syndrome is proportional to the severity of the new process that she has versus augmented by the vulnerability that these medications, which protect her heart at the risk of her blood vessels. And so I think that what's really going to be very telling, and the place that we'll stop for a breakout room, is after your next aliquot, which I think will share the exam, where we'll get to really see what this process has done to this patient with our own eyes, to start to make an educated guess about how much of this is disease versus how much of this is vulnerability from her background history. All right, Mike, to you, Anmol.
Yes, so the next aliquot, we will include the physical examination. At the time of presentation, blood pressure was 100 by 60 mmHg. Heart rate was 40 per minute. Respiratory rate was 25. And saturation was 97% via nasal prongs. The patient was afebrile. She was conscious and oriented to time, place, and person. Pallor was present, and pupils were normal, bilaterally equal in size and reacting. There was no jugular venous distension, no evidence of icterus with normal conjunctiva. S1 and S2 were heard, and there were no murmurs. Pulmonary examination was unremarkable as well, with bilateral air entry present. Abdominal exam was, the abdomen was soft. Mild diffuse tenderness was there, but without any rebound rigidity. She was conscious-oriented neuro and extremity exam was within normal limits. Regarding some early labs, if we talk about the LFTs,
can I ask you, maybe just because we covered two aliquots so quickly, I'd love to, maybe if we can try to guess what the labs are. Is that okay with you?
Yes,
Wonderful. Yeah, I think that the labs are, because I imagine that you had to wait, how long did you have to wait for the labs to come back? Maybe 1 hour?
4 hours.
4 hours. Oh my gosh. Yeah, let's make people sweat like you probably did, waiting 4 hours for the labs. So let's just do a quick, since Reza's not here, let's just do a quick breakout room. And I'd love for you all to think about, put yourself in Anmolpreet's shoes. You have this patient, you have 4 hours until the labs come back. What are you going to do in the meantime, and how will you make progress? And then, of course, we're lucky enough to actually have that data right away. So I'm going to hit pause on the recording and okay. All right, Maddie, I'm really curious. What was the conversation like in your group?
Yeah, I was with Alec and Saketh, so we had a great discussion. Some of the things we talked about were we are definitely getting a history of this person being quite volume down. And so we're anticipating some labs to reflect that. Perhaps she has an AKI from being volume down. Perhaps she has some electrolyte derangements like hypokalemia, for example, from the vomiting. We also, what stood out to us was that when she with this volume loss, and sounds like Anmol said she was initially quite hypotensive, you'd expect a tachycardia to compensate for that, but it was striking to all of us that her heart rate was 40, which is concerning because you'd expect it to be elevated to compensate. And then we were looking at the med list to see perhaps is the beta blocker, for example, contributing to that. Then the last thing we talked about was the conjunctival pallor and keeping an eye on the hemoglobin to see if that's low to reflect that. And she doesn't have any symptoms of bleeding, but she is on medication that increase her risk for those. So that's what we talked about.
Yeah, I completely agree with you. I think that that analysis is superb. Those two things jumped out to me too. And you wonder what the significance of the pallor here is, especially because even though she's at risk of bleeding with her dual antiplatelet therapy, there doesn't seem to be any evidence of blood loss happening right now. Um, yeah, and I think it just goes to show you her vulnerabilities with her medications really changed this case significantly. And I think if we did the thought experiment of how sick would she be with the same new acute process, if she didn't have these medications, and I would venture to guess that, of course, we don't know the diagnosis yet, but I would venture to guess she'd probably be a lot less sick. And so I think so far, if we're tracking how much of her disease process seems to be acute trigger versus vulnerability, I think there's so much vulnerability in her bleeding medications and her heart regimen that I think this is mostly managing the consequences of having these medications on board. And so I think that the pallor might push me to get a type-in screen from the very get-go, even in the absence of hemoglobin. And the question I'd be thinking about is, should I do anything empirically about the heart rate? And of course, we would get an ECG from the very get-go. But I think this case is a significant setup for hyperkalemia with the possibility of the spironolactone, the ramipril, and that I would ask myself, like, is this in the next 4 hours going to get worse and worse and worse on me? And should I empirically treat her for hyperkalemia? And I would even advocate for the degree of hyperkalemia here being less than what it might be to catch our attention otherwise, because of the possibility because of the concomitant effect of the beta blocker. And it's too soon to start to invoke specific diagnoses and syndromes, but when you see a heart rate of 40 in somebody who could have AKI, i.e. who could have hyperkalemia, you probably should have a pretty low threshold to use calcium gluconate. And I think if you ask yourself, what are the benefits of giving calcium gluconate in this patient, is they could temporarily improve her cardiac situation and therefore her perfusion. What are the downsides? Basically none. So if I'm there taking care of this patient, I'm lucky enough to have access to potassium in the next 3 or 4 minutes. And if I didn't, I would be very, very close to giving her calcium gluconate empirically. I think in addition to that, of course, giving her fluids is going to be really, really instrumental. And so I would probably be hydrating her as much as I can. But I think the threshold to give her calcium gluconate has been crossed, given the possibility of hyperkalemia and the presence of a beta blocker, which may have some cumulative effects in a syndromic way. But I think it's too soon to commit to that. So Anmol, you had the labs ready for us. Mike, to you, my friend.
Wonderful, wonderful discussion. since you're asking for an ECG, so I will first share the ECG.
Wonderful.
I
Thank you.
just intentionally kept the lab initially, but I'll share the ECG first.
Okay, let's do it. This is the moment where all the Academy members get to be happy because I poke them all the time and make them read things and pictures and x-rays, and poor Simi today had to read a hip osteonecrosis x-ray. So this is your revenge, guys. I'll tackle the CKG. It's almost there. Oi, oi, oi. Simi, are you able to unmute? I don't know, because you said the magic words. I don't know if you can, but I'll give you yeah.
Yes, probably I can unmute, but I'm not very good at EKGs, but I can just try, and I just know what you have taught
No,
us.
no. I would never make you read an EKG, but you said something in the chat. What did you say in the chat?
Yes, probably when we have a slow heart rate, which looks like the case here, and we have wide QRS, then we can think about hyperkalemia, and also given the low heart rate and patient's condition, that looks likely, but would love to learn more from you.
Yeah, you nailed it. Absolutely right. Yeah, I think so Anmol, here we have I'm trying to look at the rhythm. I don't see any atrial activity. And so I think I would come to the conclusion that this is a junctional rhythm. And it's a regular rhythm that the QRS, I'm looking at V3 because I can see the boxes the most. The QRS is approaching 3 boxes. So it's borderline wide. And so that for me triggers the reflex of slow and wide equals hyperkalemia. And so I think with this EKG, I would definitely empirically treat with calcium gluconate, with knowing that there are a few downsides. I also see very poor R wave progression and low amplitude leads and all the precordium. And so I would wonder, why is it that she has such little electricity? And it may be because she has such little myocardium from extensive myocardial infarctions atrophying her myocardium, or she has something in the way between her myocardium and our EKG machine. Most alarmingly would be a pericardial effusion, and most benign would be increased adiposity. The things in between adiposity on the chest wall and a pericardial effusion would be air in the lungs in the form of COPD, or problems in the pleura. Hopefully not a pneumothorax, but possibly a pleural effusion. So her BMI would be information that I think we would have. And so if that were not high, the exam can also help us figure out if she has lung or pleural disease, leaving us with the hypothesis that she might have either extensive prior MIs or a pericardial process. I don't see any electrical alternans, and she's definitely not tachycardic. So I'm toying between either that her BMI is elevated or that she has had extensive prior infarcts causing a thin myocardium. Yeah, I really, really worry about her. And I think I would give her calcium gluconate. And if I'm being more authentic about my thoughts, I'm ready for her potassium to be 5.1. And for you all to wonder, wait, it's not that hyperkalemic, but I will tell you a potassium that is not that high in this patient can effectively be very serious. And we can, if we're going there, we'll see what her potassium is. If we're going there, we can zoom in on that concept. But the consequences of hyperkalemia may be amplified in her by the presence of a beta blocker. So I'm very worried about that because that diagnosis is very serious and can make the patient pretty sick for some time. All right, Anmol, Mike, to you. What do you have for us next?
Going in the right direction, Dr. Rabih, then we actually got an arterial blood gas analysis
Yes.
for the patient. So that the reports will come a little late. So we got an APG that it showed a pH of 7.37, a PCO2 of 24, sodium of 123, potassium of 7, glucose was 103, lactate was 0.9, and bicarbs were 13.9.
Okay.
That was the ABG results.
Yeah.
And but I will also share some of the lab results which came a little late.
Sure.
The LFT showed the total serum bilirubin to be normal. AST, ALT were normal at 25 and 19. Serum total protein was normal, albumin was normal, alk phos was normal as well. Regarding the total cholesterol, it was 96, and HB was 10.7 with an MCV of 98. TLC were slightly raised at 11,400, and platelets were 1,56,000. So this was about the LFT and the ABG, and the serum electrolytes, which came later, confirmed the findings of hyperkalemia with raised potassium, and sodium was 125. Hyponatremia was there. Calcium was 9.4. Magnesium was 1.5, and phosphorus was 3.9. Amylase was 90, and lipase was 62. So that was about the labs. I just have a few more labs after this. I will stop here.
Yeah, Anmol, do you? I may have misheard it. I may have not heard it. Did you mention the creatinine, or are you saving that for later?
I have not mentioned it yet.
Okay. All right. Very good. I like that strategy. Expert presenter. Okay. Team, time for more breakout rooms. So the question I would ask for you is, what will you do now? What are you thinking, and what would you do? And we'll do another breakout room, and I'll see you all in 5 minutes. All right, guys, welcome back. All right, Maddie, round two. You ready? You're there. You're taking care of this patient. What do you think you'd do?
Oh gosh. All right. So we talked a lot about just management of hyperkalemia here. And so, as you said, calcium gluconate to stabilize the cardiac membrane, but then also considering options that would kind of shift potassium into the cells. So you can use insulin, ND5, Lokelma as well, giving fluids to this patient. And that's what we talked about. That's what we talked about.
Awesome. Yeah, I'm right there with you. I think you really have to focus on hyperkalemia treatment here. I think it potentially has very serious consequences. I think that it's probably helpful to take a moment or two to iron out the principles behind hyperkalemia treatment. So most of the potassium in our body is found inside cells. And the serum potassium accounts for a very, very small fraction, single percent of potassium in our body. And so the principles of hyperkalemia, where the serum potassium is elevated, is to quickly lower the potassium by either getting it out of the body or temporarily storing it inside cells. That is key to temporize the problem, either getting it out or forcing it intracellularly to lower the serum potassium. However, these are non-specific treatments that do not get at the underlying cause. The most important aspect of the treatment of hyperkalemia to do in every single patient is to treat the underlying issue that got the patient got there in the first place. 99.99999% of the time, the underlying issue is kidney dysfunction. So we would be in the 0.00001% chance of reality if Anmol unmuted and said her creatinine is normal. And if I were feeling bold, I would offer to quit my job forever if her creatinine is not abnormal. That's how confident I am that it would be. And the truth is, in medicine, you don't want to get too confident. You want to be careful because medicine is full of surprises, but you have to be honest about what the pretest probability is. If her creatinine is normal, then what I would do is first probably get a cystatin C and doubt her creatinine. And then if that's also normal, then I would wonder if she has pseudo hyperkalemia or a fake out. But the probability of pseudo hyperkalemia is very low when you have an EKG that's very compatible with true hyperkalemia. So those are the possibilities. So the probability of pseudo hyperkalemia here is very low because you have a patient who is wide and slow. So what would I do? You always, always, always have to treat the underlying cause. Maddie said from a long time ago that she expects this patient to have AKI from hypovolemia, from the medications that she is taking, and from dehydration from the gastrointestinal loss. So what is the single most important thing you need to do about hyperkalemia is to treat the presumptive cause, which is AKI, by hydrating, 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 hydrating. If you do not treat the underlying cause and just remove potassium from the body or dump it into cells, guess what happens after the Lokelma, K-oxalate, Lasix, insulin, and D50? What happens after they've been vanished from the body? The patient's right back where she started. So this is really important. The most important thing you can do for all patients with hyperkalemia is to treat the underlying cause. Now, here's the problem. It takes hours, days, or maybe never to be able to effectively treat the underlying cause. For example, if the underlying cause is end-stage renal disease requiring dialysis, you're going to need at least 3 hours to get the patient hooked and treated. So in some patients for whom treating the underlying cause is not sufficient, you need to do targeted supportive care, meaning that you try to eliminate the potassium from the body or push it into cells. Now, if you are in that situation where you cannot wait to treat the underlying cause, what option do you use? Eliminate it from the body or temporarily store it in cells? And the answer is a little bit complicated. Storing it in cells temporarily with insulin and D50 is an incredibly effective mechanism, except it has significant side effects. How strong it is on potassium is also how strong it is on glucose, and the risk of hypoglycemia with insulin and D50 is high. So it's a powerful punch against potassium, but it causes a lot of bystander consequences. Elimination from the body is not as quick, but it comes with less side effect and with less rebound hyperkalemia, because at least you got that out of the body. So what happens in real life? If you are going to institute supportive care because you're worried that the underlying cause will not be treated enough, you should always, always, always eliminate the potassium from the body by giving either Lasix or GI loss, always. If in patients, the potassium is so high that you can't even wait the 30 minutes or the hour to eliminate it from the body, you need to give those patients intracellular shifting therapy. Who gets calcium? You should always give calcium if you're giving intracellular therapy, because if you're saying that the potassium is so high that I'm going to take the risk of making this patient hypoglycemic, that means that the patient's too risky and has to get calcium. So if you are saying you don't have time, the patient gets IV calcium, insulin, and D50. If you're saying you have a little bit of time, you can do elimination from the body. If you're saying you have a lot of time, the potassium is only 5.1, just treat the underlying cause. So what would I do in this patient? I think in the absence of the creatinine, it creates a little bit of a dilemma about whether this potassium is real or not, and whether the patient is going to benefit from lowering their potassium or not, because the vast majority of hyperkalemia occurs in the context of kidney dysfunction. So the validity of this test and the accuracy of this test is in question. However, the probability that is real is elevated almost to 100% for three reasons. The first is it's elevated on two tests, the point of care of ABG and the serum potassium. The second is that the patient has a compatible clinical syndrome with bradycardia that's wide and narrow. And the third is this is a life-threatening possibility that the alternative hypothesis is not equally as morbid as this. So I would give this patient a lot of fluids. I would also give her Lasix, and even more fluids because I gave her Lasix. And I would also give her calcium gluconate, and I would also give her insulin and D50. Because we don't know the creatinine yet, I would give her a lot less insulin than I normally would. So if somebody has a normal creatinine, we often give them 10 units of IV insulin plus an amp of D50. But because I anticipate this patient to have significant kidney dysfunction, I would only give her 5 units of insulin, which is effective for her potassium and incurs much less risk of hypoglycemia. Anmol, short and sweet, no more. Long and very complicated. But I will hand you the mic to tell us what you have next.
Thank you, Dr. Rabih, for such rich discussion and making this VMR so good. And you, as you just said, creatinine for this patient was 3.52 with the BUN of 83. Urinalysis at the time of presentation was normal. CHOP-T was mildly raised at 0.036 and BNP was 405. I think no more testing was done for this patient. Basically, she was, when we found that her potassium was raised, she was treated for the hyperkalemia. We gave her injection calcium gluconate. We gave her soda bicarb because her ABG was also suggestive of compensated metabolic acidosis. So we also gave her sodium bicarbonate and insulin as well. And after that, the blood reports showed the evidence of raised creatinine. That was a question mark in my mind. And when I searched about it, then I realized that actually this patient is fitting in the category of Brash syndrome. And actually she improved with IV fluids. Transcutaneous pacing was done for this patient because her heart rate reached 25. So transcutaneous pacing was done. She was put on dopamine infusion. But with the hyperkalemia that we treated and with the IV fluids, her rate reverted itself to normal sinus rhythm. And I have the normal ECG after that as well. So I actually searched about Brash syndrome after that, and the literature said that it is rare, but I have actually seen 2 to 3 cases in the hospital with Brash syndrome, and I will share the second one as well. So what I studied about Brash syndrome is that it was first time described in 2016, and it stands for bradycardia, renal failure, atrioventricular blockade, shock, and hyperkalemia. So all of these components were present in this patient. And the pathophysiology, as you said, it is like that if there is some volume depleting illness or a disposing illness to the kidney, so that they are not able to excrete out potassium or the AV nodal blocking drugs. So the AV nodal blocking drugs and potassium, they accumulate to cause a synergistic bradycardia. And that synergistic bradycardia then again decreases the cardiac output, and that decreased cardiac output again causes the renal injury. So that is, the loop actually continues. So that is what I studied about Brash syndrome. And there was just one another case I saw in the hospital. It was a case of a 58 years old male who had a past history of type 2 diabetes, chronic liver disease because of alcohol, complicated by cirrhosis, and esophageal varices grade 2. So he was taking tablet carvedilol 3.125 twice daily. And he also had loose stools and some volume depleting illness was there. So his he just came to us, and his ECG was suggestive of junctional bradycardia, that his heart rate was low as well. And he also got better with the IV fluids, treatment of hyperkalemia. So they were the two cases I saw simultaneously for Brash syndrome. And my learning point from this case was that while working in the cardiac emergency, I think we mostly, when we see bradycardia, we think about, we see many cases of complete heart block, and then they are posted for temporary transvenous spacing. But to understand and read the ECG carefully, what that rhythm is showing, if that is junctional bradycardia, then what is the cause of that junctional bradycardia, treating that cause, and avoiding unnecessary percutaneous interventions is, I believe, is important. That is what my takeaway from this case was. And for the last, I will also like to show the ECG I saw for the next patient. That was another case with the junctional bradycardia. One second. This was the second ECG for the patient, another patient.
Yeah, wow. I mean, I think that again, you have the same very principles. It's slow. There's no atrial activity, and I think what's interesting about this EKG is you see the T wave morphology, especially in the anterior lead, is it's especially in V2, V3, V4, V5, V6 is peaked. You can see that the height of the T wave is higher than a quarter of the QRS. So if you look at actually, that's not necessarily true for the, I was thinking about the prior EKG, but in almost all the leads, you can see that the height of the height of the T wave rivals that of the QRS. So the T waves are also evocative of hyperkalemia here. I will tell you, slow, the first reflex for somebody who's bradycardic is ischemia, 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 and the second is hyperkalemia. And we take too long to give these patients calcium gluconate. It's a life-saving medication. Anmol, this is such an incredible journey that you just took us on. I think that, yeah, this is, in many ways, this is what is, I think, you're right, that this is a bread and butter case. You have seen it yourself so many times. But I will tell you that I think most of these cases, if you look back upon them, you realize that there was an opportunity to deliver more effective and efficient care to the patient. And I think by giving us the chance to stop early on and see in somebody who should have been in hypovolemic shock actually has a cardiogenic component to their hypotension with the heart rate is a big, big, big place for I think many mistakes in real life, and hopefully everyone who is here and those who are listening on YouTube can realize that they can actually effectively better care for patients when they realize how what I said about your cases remains true. You think you're going right, and the patient is in hypovolemic shock based on the history, but all of a sudden you have to turn around and go a completely different direction because of the heart rate. So really, really excellent case. Anmol, is there any one or two teaching points that you want to re-emphasize in the cloud of many learning points before we have Saket do the same?
Yes, I think whenever in the emergency or any place we see these two things, isolated, we see bradycardia, or isolated hyperkalemia, it is important to evaluate the cause for both of them. I think that is the main key point I took away from this case. And even after seeing this case, when I put my progress notes in the hospital, I'm always like, if I write hyperkalemia, I put a question mark that these are the possible causes for this. Now I have to rule out one by one, because if we treat those causes, the hyperkalemia is treated. We can give calcium gluconate, we can give all the things, but then it will come back again if we don't treat the primary cause. So that was one thing I learned. And bradycardia, as I said, working in a busy cardiac emergency, we see so many bradycardia patients and many complete heart blocks. So they are immediately posted for transvenous pacing if we don't see any apparent reversible cause. But to identify this rhythm and to identify that this has a potential reversible cause and not put the patient for unnecessary interventions which can lead to infection, I think that they were the main key takeaway points for me. And I think when we discuss the case and when we see those cases in the hospital, it's both are quite different journeys. But I really learned a lot from this VMR. Thank you so much.
Of course, thank you for presenting and for emphasizing those very important points. You gave your patient fluids instead of a pacemaker, and I think they're very, very happy for that. All right, Sakid, take it away, my friend.
Hello. Yeah, so really interesting case, and thank you so much. So we started off with nausea and vomiting and diarrhea that this patient had, and with nausea, vomiting, and diarrhea, we were thinking most likely there is an involvement of the entire GI tract, other than just nausea or vomiting, which makes it more unlikely. Also, it's important to remember that you need a very high degree of nausea, vomiting, and diarrhea to actually cause hypotension in a patient. And considering the age of this patient being more than 50 years of age, along with abdominal pain and nausea and vomiting, MI is something that needs consideration. And we absolutely need to get an EKG to rule that out. Also, the drug history that this patient has, being on a host of drugs, including beta blockers, diuretics, they should have a lower threshold for hypotension. And also considering the age, so important to keep that in mind as well. The medication history is even more important because this makes the patient a lot more vulnerable to a host of complications, including electrolyte derangements, with her being on beta blockers. Also, compromised perfusion, the drugs could cause bradycardia, hypertension. So very important to keep a very like you need to be very comprehensive about the drug history in especially older age groups. Yeah, so after that, this scenario makes getting a potassium very likely. So get the potassium ASAP. If you can't get the serum potassium immediately through the CMP, get an ABG. As soon as get the potassium, the whole scenario makes basically gives you a very low threshold for calcium gluconate in this patient. And as soon as we saw the EKG, we saw that there was no atrial activity, most likely a junctional rhythm, and there was a wide QRS and bradycardia, which makes us think of hyperkalemia in this scenario. This is even before we got the serum potassium, so that's a sign as well. Also, the low voltage voltage and precordial leaks makes us think there could be causes that's causing a delay in the transmission of the impulses to the surface. So make sure you do a quick exam, look at the VMR of the patient that could be hindering that. Also, something that needs consideration is looking at if there's any pleural or pericardial disease. And coming to the management part of hyperkalemia that this patient had, always focus on treating the underlying cause, because unless you do that, no matter what you do, it's probably gonna come back and haunt you. So yeah, so focus on treating the underlying cause and stabilize the cardiac membrane with calcium gluconate. Remember that insulin plus D50 is a very powerful move to shift the potassium intracellularly, but also it's important to think about hypoglycemia in this patient. Make sure you're not causing more harm than benefit. And hyperkalemia should always be thought of as secondary to kidney, something with the kidney, unless proven otherwise. So make sure you check the creatinine. And if this patient has a low BMI, looks malnourished, if there is any evidence of muscle loss, make sure you get a cystatin C as well. That's a very important marker as well. So finally, we found out that the patient had something called BRASH syndrome, which is bradycardia, renal failure, AV block, shock, and hyperkalemia. The essential takeaway was to make sure you do a thorough workup for any case of bradycardia or AV block that you see in the ED or hyperkalemia, because most often when you have a reversible cause, you can avoid a lot of unnecessary interventions. Yeah, I think that sums it up.
That was an excellent summary. As many people have said, it's hard to believe this is your first time compiling the teaching points. I think It's a lot harder than it seems to have to recap all learning along the way. And I think you did an excellent job. Thank you so much, Saket. I imagine you probably feel a little bit differently than what I just said, which is also a universal feature of having to do these teaching points. Anmol, thank you so much for an incredible hour. Zakaria, really impressive scribing skills there, keeping up with such a complicated case. And I hope you guys enjoyed hanging out with each other and sharing your thoughts, and look forward to seeing you all next time. Bye.